Sorry, excuse me, I didn't mean to cough in your ear to start with. I just started my timer because I know that whenever I'm talking in front of my computer and I don't get to see you guys in person, that I don't see whenever you start getting bored. So I start talking a lot. So I'm going to set my timer so I can see it in front of me, and we'll go ahead and get started. So our lecture today, so I'm Jennifer Franco. You know, we've talked before with the GI lectures and the intro to pathogenic bacteria in the fall. The lecture today, we're going to end up covering sexually transmitted infections. I should maybe preface this by saying we're going to be talking about bacterial infections that cause sexually transmitted diseases. And the main ones that we're going to cover, although I have a couple other slides added into this, are going to be chlamydia, gonorrhea, and syphilis. So the reason why I have them focused on here is, and going to be the main focus of the actual lecture, is because they're the most common to the United States. Some of the other ones I'm going to put a slide in for and discuss a little bit are not going to be necessarily as common in the United States, but are important worldwide. So a couple of things I want you guys to pay attention to is that all three of these diseases are reportable diseases. So if you end up seeing cases of these, they will need to be reported. Chlamydia trachomatis is basically going to end up being the #1 bacterial infection that's reported overall. So if we're talking about infectious diseases and bacterial infections, this is going to be the #1, not just the #1 reported STI, but in general infectious diseases you're going to end up seeing. Here we see about 1.8 million people are reportedly infected with it per year. They think that this is a really underestimate of how many people are actually infected, and they think that this is probably closer to about 3 million people per year that are actually infected. You see that's a huge number. You end up seeing, you know, a good number of people are infected with Neisseria gonorrhea. That's going to be the causative agent of gonorrhea. And there's a lower number that's actually infected with Treponema pallidum, the causative agent of syphilis. And you might be thinking, well, why are we talking about syphilis? You know, syphilis isn't a problem anymore, and that's not true. What they're seeing for all of these bacterial STIs is that there's been, in the last 5 or 10 years, a significant increase in the number of cases of these. So it's going to be something that we're going to see as you look at some of the epidemiologic data that the CDC collects. So down here, you end up seeing a link that if you want to go and learn more about this epidemiologic data, you can go back. They basically do these surveillance surveys throughout the years, and you can go back prior to the advent of antibiotics, and you'll see that there's a very high rate of infection. You see when antibiotics came into play, there's a huge drop, and since then you're starting to see a rise in cases again. So all of these are going to be important, and we're going to try to break them down. I'm going to start from a lecture perspective. We're going to talk about chlamydia first. We'll go on to talk about gonorrhea, and then we'll talk about syphilis, basically in the order of incidence as we're going through. So as we go through, I guess I have to change it on this one. For your learning objectives, basically make sure you know the bacteriologic characteristics of each of these. Are they gram-positive, are they gram-negative? What are important virulence factors associated with them? What are the diseases that they cause, the signs and symptoms associated with it? How are you going to prevent or treat them? And the importance from a public health concerns. Again, for my lectures, I try to make things that I think that are important in blue so you can kind of follow along. And I'm not going to say that everything is going to end up being in blue, but some of the important points I want you to take away from the slides are in blue. So starting off and talking about chlamydial infections, as I already said, they get the gold star for being the most prevalent, and this is both infectious disease and sexually transmitted. So a couple of things to pay attention to on this. This is going to be something that you're going to see with chlamydia, is that from a reporting standpoint, it tends to have a higher prevalence in women versus men. When we start looking at gonorrheal infections and infections in syphilis, what you're going to end up seeing is that trend tends to be reversed, and there tends to be more men infected compared to women. The people that you see infected are going to be those that are between 15 and 29 years old, which makes sense because this tends to be the most sexually active population that are having multiple partners. So one of the things that you're going to see, and I'm going to say this over and over again, there's not necessarily vaccines against any of these STIs, and I'll explain a little bit more about that in later slides. But the big thing it's going to be is minimizing the risk and exposures. So in order to deal with exposures in these populations, we're really going to be talking about prevention, condom use, not having multiple sexual partners, those type of things. So it's really going to be something important. The prevention part is really going to be important. I threw in this slide over here. This is also from that CDC surveillance that came out in 2018. This is going through and looking at the number of cases per year in each of the states. We can be happy that West Virginia is actually one of the lowest. It's actually the lowest for the rate of infection in the United States. And you'll see that that holds true for all of the different sexually transmitted diseases. Okay, a little bit about the bacteriology of chlamydia trachomatis. So what you're going to see is that this is going to be a gram-negative bacteria. It's going to be an obligate intracellular pathogen, and that's going to be a big deal when we talk about the pathogenesis of it. It's roughly spherical, but it's not usually considered a cocci, so sometimes it's kind of like a little bit more kidney bean shape when people talk about it. Peptidoglycan. So we talk about peptidoglycan in the context of cell walls. One thing that's kind of controversial about chlamydia is whether or not it actually has peptidoglycan. So it is believed that it does not have the enzymes that are capable of making muramic acid that's going to be part of that peptidoglycan cell wall. So why is that important? That's important because when we start talking about antibiotics used to treat the infections, we're going to make sure that you're not going to give a beta-lactam antibiotic that's going to target peptidoglycan cell walls, right? So you're going to end up seeing that the antibiotics that are going to be used for this are going to be ones that inhibit protein synthesis rather than target cell wall synthesis. The other thing you see here is that these guys have a really small genome, and this is kind of related to that intracellular pathogenness of them. So what I mean by this is oftentimes if you are, evolutionary speaking, if you can get what you need from somebody else, you don't have to carry those genes with you to produce enzymes and proteins that are going to produce those things. So for the bacteria themselves, since they're living intracellularly, they're basically a parasite and can end up leaching amino acids, nucleic acids, actual nutrients, ATP from the host. And as a result of that, they have this really small genome associated with them. So we're going to talk about 3 different biovars during this the lecture. These biovars are going to end up causing different types of diseases. So you'll end up seeing, we'll talk a little bit about strains A through C, strains D through K, and strains L1 through L3. The one that we're going to spend the most time is talking about this D through K, because that is going to be the one that causes the common bacterial STIs that we end up seeing in the United States. I do want to make you aware that these other strains like A through C are going to be associated with trachoma, which is going to be the development or cause eye infections. And they're really the #1 cause of blindness worldwide. Strains L1 through L3 end up causing a more invasive disease that's going to be referred to as lymphogranuloma I can't talk today, venereum, sorry. Which is going to end up being abbreviated as LGV. This is going to be a more invasive disease where you're going to end up having lymph, swelling of the lymph nodes in these buboes. We're going to end up having some pictures of those later on and explain the pathology of those a little bit. So talking about the actual strains D through K, which causes bacterial infections. It's going to be transmitted sexually or from mother to infant during a vaginal birth. From the adult transmission, that's going to be related to sexual transmission. What you're going to see for symptoms are going to be in males. They're going to end up developing this painful watery discharge. They can get inflammation of the male genital, the male reproductive tract. It could start out as urethritis. But as the inflammation proceeds up, you can end up getting inflammation of the other portions of the male reproductive tract. One thing I want you to pay attention to is that this watery discharge that you end up seeing with chlamydial infections, that tends to be a little bit different whenever you see males that have gonorrheal infections. And whenever you see gonorrheal infections, what you're going to end up seeing is kind of a purulent kind of, colored discharge. And that's related to the fact that there's a more neutrophil involvement with the gonorrheal infections. But that is a good thing to think about whenever you're thinking about diagnostics. For the females, again, you're going to have inflammation of the reproductive tract, going from the cervix all the way up, potentially into the fallopian tubes. The downfall or the unfortunateness about females being infected is that there is a good proportion of females that don't actually end up clearing the infections. Many do, but those that don't can end up having this chronic inflammation that they're not necessarily aware of. And that can result in the development of pelvic inflammatory disease and basically the death of the ciliated epithelial cells in the fallopian tubes, which can end up resulting in ectopic pregnancy or infertility. In infants, those that get infected whenever you end up having exposures via a vaginal delivery is going to include these eye infections, the conjunctivitis, as well as potentially the development of pneumonia. Excuse me. These are going to be, this is one of the reasons why good prenatal care is really important, because if somebody has been diagnosed with chlamydial infections, basically they can give them antibiotics in order to reduce the potential of this ending up happening. Another more invasive presentation that you might end up seeing is this thing that's called Reiter syndrome. And basically this is a combination, it's like a triad of symptoms that end up occurring that includes arthritis, urethritis, and conjunctivitis. The arthritis that you end up seeing here is basically due to the patient developing antibodies, and those antibodies cross-reacting to proteins that are self-proteins that would be present within your joints. So if you have somebody that has a swollen knee, you take some synovial fluid and you end up looking, you can end up seeing, well, so you don't end up seeing it, but antibody complexes can be present there, and it causes the inflammation that causes the arthritis. So it's really like a cross-reactivity effect. From a pathogenesis standpoint, I want to give you guys a little bit of overview of this just because I think it's important to understand how the cells end up dying. But it is kind of complicated. You end up seeing that there's two different life cycle stages, these elementary bodies versus the reticulate bodies. The reticulate bodies are going to be the replicating form that live intracellularly. I'm going to show this on the next slide of how it kind of ends up working. But what will happen is that these elementary bodies are going to bind to epithelial cells within the reproductive tract. They'll be internalized, and then once they're internalized, they'll differentiate into these reticulate bodies and basically live and replicate within the cells. So when this ends up happening, you'll end up seeing these big inclusions end up forming. So it's basically what happens is that it basically causes all these phagolysosomes to kind of fuse together. And you get these big inclusions forming here, and you get replication of those reticular bodies within there. I already mentioned that these guys were intracellular parasites, so they can basically, they don't necessarily produce a lot of ATP. And what they have are these translocases that can basically transport that energy as well as nutrients into the, from the host cell into their cells and utilize them. So you can end up having lysis of the cell, or not lysis of the cells, but death of the cells because of its parasitic type. I'm doing air quotes. I don't know if you can see me at the moment or not. I don't think so. The parasitic methods, right, that they're kind of being leeches. But as these inclusion bodies get really big and you have replication of these reticulate bodies in the cell, eventually these cells will lyse and they'll go on to the bacterial cells will be able to go on and infect other cells. So one of the things, so I'm gonna zip over to the next slide to kind of show this happening. This is the elementary bodies binding to the epithelial cells. They get internalized. You end up having them differentiate into the reticulate bodies. They start dividing. You have these vesicles basically butting together to form these big inclusions. Then some of these differentiate back in those elementary bodies, the cell lyses, and then these can go and reinfect the other cells. The reason I bring this up is because it's not really easy to culture these. And as a result of it not being easily culturable because they're intracellular pathogens, if you wanted to culture them, you have to actually have human cells and do tissue culture work. You're not necessarily going to just take an agar plate and streak out a cervical swab to see what grows on it, because these aren't just going to grow on regular agar plates because they're obligately intracellular. So we have to use different techniques like nucleic acid amplification tests like PCR in order to identify them. So I added this in. I'm not going to take the time for the look for here, but on your own, you can watch the video that shows one of those big inclusions, the lysis of the cell and the bacteria being basically those elementary bodies being released out into the environment. So I already talked about the transmission, right? Infected secretions, that's going to be from sexual intercourse. Newborns passing through the vaginal canal, those are the bacteria, those elementary bodies are going to bind to the receptors. They're going to be internalized. They inhibit phagolysosome fusion. You get that inclusion formation. And then as a result of that, those cells lyse. You can imagine a cell lyse, you get lots of inflammation, you get exposure to the immune system. As a result of that, you get a lot of inflammation happening. So for acute inflammation symptoms, right, you're going to get these inflammatory mediators that's going to result in the recruitment of immune cells there. But the ones that tend to be the more problematic is these long-term chronic inflammation that results in those endothelial cell necrosis. Then you have fibroblasts come back in, and then you get scar formation. And this is particularly damaging when we're talking about the female reproductive tract and it happening within the fallopian tubes, because that's basically going to result, you know, if you have an asymptomatic chlamydial infection, if you have that chronic inflammation, basically those ciliated epithelial cells that would typically move that egg down the reproductive tract, you're going to not have that happen anymore, resulting in infertility. Or if it does happen, but it only gets to this location, you can end up with an ectopic pregnancy happening. So that's kind of how the problematic end of it happens with in the female infected patients. For the other biovars, the trachoma that ends up happening is basically the inflammation of the cornea. How this ends up happening is that you have infection of the eyelid most often what ends up happening. And it's not necessarily the bacteria itself that's causing the damage to the eye. It's the fact that you get this inflammation of that eyelid, and then you have the eyelashes kind of turn inward where they're going to scrape up against the cornea and basically damage that vision field. So this is going to be the leading cause of blindness worldwide, and as I mentioned before. And I should mention that this isn't always sexually transmitted. So it could be that you touch your eye, and you'll become infected in that way. From the idea of this lymphogranular venereum, I said that I would talk a little bit about this, about the mechanism. So what happens here is that instead of this being localized to the right reproductive tract, what's going to happen is it's going to have the infection of the lymphatics and the lymph nodes. So whenever it gets into the lymph nodes, what happens is that it can multiply within the mononuclear phagocytes in the lymph nodes, right? You get granuloma formation as a result of that. And this could result in the blockage of the drainage from that lymph node. So the buboes are these big lymph nodes that end up developing as a result of that is really the result of granuloma formation that's going to prevent lymphatic drainage. Sorry, I'm having trouble going back through from back to screens. So for diagnosis, I already mentioned it's going to be really important for the nucleic amplification tests or PCR. You can also use immunologic techniques. When we're talking about immunologic techniques, we're going to be talking about things like ELISAs or using fluorescent antibodies that are going to be specific to the bacteria itself to identify it. From a treatment mechanism, this is going to be something that you're going to see is going to be very similar to when we talk about gonorrhea, because most people that are, well, I shouldn't say most people, about half the people that are infected with chlamydia end up also being infected with gonorrhea. So what you'll end up seeing is oftentimes what's going to be called for is that you are going to end up treating both infections at the same time if you know that there are both infections there, or you can't exclude the other one from not being there. So for chlamydia, you're going to use those protein inhibitors like doxycycline or azithromycin. For gonorrhea infections, you're going to end up using beta-lactams that it's going to have. The beta-lactam, the peptidoglycan targeting antibiotics. The other thing that you're going to, so one other thing that you should see. So now Doxycycline is actually the one that the CDC actually suggests rather than azithromycin, because there's actually starting to be an increase in gonorrhea that is resistant to azithromycin. And I'll show that slide later on. But if you are a pregnant female, you don't want to be taking doxycycline, so you will need to take azithromycin in order to deal with the chlamydial infection. The other thing that's going to be really important is the fact that you need to treat both partners, because even if you treat one partner and then it moves on, so it's treatment, they're cured, they can get reinfected by the same partner that's already been infected. So treating both partners is going to be important. Treating both gonorrhea and chlamydia is going to be important in that aspect. Prevention, there's no vaccines available. So again, we're going to try to limit exposures rather, so limiting sexual partners, using condoms, or other protective mechanisms in order to prevent the actual exposure to the bacteria. Okay, so going on and talking about Neisseria gonorrhea, the causative agent of gonorrhea. As I mentioned earlier, for chlamydia, women tend to be diagnosed more often than men. For gonorrhea, you're going to see men are more often diagnosed than females. Going back to this whole idea that we see in the last 5 to 10 years, this increase in gonorrheal infections is important because we know it's reemerging. But if you put this on the big scale, going back all the way to the 1940s, right, you can see when this isn't the highest peak we've ever been, but we're starting to see that blip come up again. So same things, I already mentioned the diagnosed more often in men than women. Again, you're going to see 15 to 29-year-olds are the most at risk. And this blip that we see that's coming up again here, they think the cause of this is basically the emergence of these antibiotic resistant strains of gonorrhea. So what we're going to start seeing, and this is actually going to impact what antibiotics the CDC is going to recommend you using for these infections, is that approximately 40% of all gonorrheal strains right now are resistant to penicillin. So you're going to start seeing different uses as a result of that increase in antibiotic resistance. So going through the bacteriology of this, it's going to be a gram-negative cocci. It's frequently seen in pairs. Be careful with my little cartoon over here. These look like they're kind of purpley. It should be pink because they're gram-negative, right? But a couple things that as you look at, if you're going to do a diagnosis of this, yes, you'll see these paired cocci that are gram-negative. But the other thing that you'll see is that these are often inside of neutrophils. So you'll see that they can infect neutrophils. You'll see that in males, they tend to have this purulent urethral discharge that's going to be associated with its symptoms. And that has to really do with those neutrophils being present, eventually dying, being recruited to the site of inflammation, being infected, dying off, and then you see that the purulent discharge as a result of that. Similar to chlamydial infections, you'll see that females tend to be asymptomatic. The problem with that is that you have chronic inflammation that lives the pelvic inflammatory disease. So a lot of this is the same when it comes for presentations for females. For males, the difference is the watery discharge versus the purulent discharge. This can also cause conjunctivitis in children whenever it passes through if they have an infected mother as it passes through the vaginal canal. But this can also cause some other disseminated infections that we'll come back to in a little bit here. So from a pathogenesis standpoint, what you're going to end up seeing, whether this is a result of exposure because of it, sexual transmission, or it being because the child has passed through an infected vaginal canal, is you're going to see that these bacteria are going to end up being able to attach to those columnar epithelial cells, and that's what you see here. So they're the ones that are not going to be ciliated. They're going to be able to penetrate these and get into kind of like the subepithelium, and in this area, they're going to induce an inflammatory response. And once they get this inflammatory response going, those macrophages and neutrophils, right? Neutrophils will be the first ones to get there. Macrophages will come in later. Those neutrophils and macrophages are really good at inducing or secreting inflammatory cytokines. So it's these cytokines, the TNF alpha and some of these other cytokines that are going to end up resulting in the death of these other cells. And the death of these other cells are what's going to really give the symptoms that are going for the females that are going to result in that chronic inflammation and potentially develop that pelvic inflammatory disease that can result in infertility and or ectopic pregnancies. So again, we're not going to end up seeing the symptoms necessarily in the females. The males are going to have those neutrophils that are dying and the bacteria sloughing off and making the permanent discharge. But this happening within the female reproductive tract tends to go unnoticed for long periods of time. And this is that slide, another slide showing the electromicrograph. And this is actually looking within the fallopian tubes of a woman who has been infected. And what you end up seeing is the bacteria are actually binding to the non-ciliated epithelial cells. And they're going to, as I mentioned back here, that they're going to end up being able to cross those, induce inflammation, and the inflammatory cytokines are going to end up killing these guys. Oops, in the wrong direction. And you can see those ciliated epithelial cells there. So again, males, the inflammatory response, urethritis, painful urination. This tends to be yellow, pus-like. Females, you get the cervical. You can have a cervical discharge. This tends to be kind of watery, greenish kind of color. You can end up getting the inflammation of the other parts of the female reproductive tract. But again, it's the same effect whenever you have those long-term chronic inflammation. And that's emphasizing females tend to be asymptomatic versus males. You see this come up. It's starting to get repetitive now of me saying it over and over again. Some other things that make it so that Neisseria ends up, the pathogenesis of that's associated with the pathogenesis of Neisseria is that it kind of tends to hide away from the immune system per se. Some of that is because it can live intracellularly, but this is more often mediated by these two other mechanisms here. One is that it can actually produce these proteases that'll cleave IgA. So as you can imagine, the reproductive tract ends up being a mucosal surface. So from an immune standpoint, you're going to want to produce IgA to prevent the binding of these bacteria to the epithelial cells to start with. If your body produces IgA, the bacteria basically laugh and produce these proteases that can cleave the IgA that prevents it from neutralizing the bacteria. It can bind, it can evade. It also ends up undergoing antigenic variation. So what happens here is the pili that end up binding to those epithelial cells, if you get infected, you produce antibodies against these pili, right? So you clear the infection, but what the bacteria will end up doing is that it knows it gets cleared, so it can basically start expressing a different pili on its surface so that your antibodies that you've produced aren't going to end up recognizing it anymore. If you get reinfection, you produce an immune response again. You start clearing the bacteria start producing a different pili on its cell surface. I mentioned this process back before whenever we talked about the intro to pathogenic bacteria and the fact that this is kind of a process kind of similar to T cell or B cell receptor rearrangement, where they take these little pieces of genes and pop them in, and then they express a different gene as a result of these different loci being incorporated into the gene. But this antigenic variation happens not only in Neisseria gonorrhea, it's also going to be play a role in Treponema pallidum, so the causative agent of syphilis, in its pathogenesis. And what ends up happening is that this makes it really hard to develop vaccines if the bacteria is able to continuously change what surface antigens they end up having. Other complications that are associated with Neisseria gonorrhea infections, this conjunctivitis that's the result of the mom being infected. You can see the purulent discharge again from the child's eyes. You can treat this with antibiotics, so you can use azithromycin if you're going to for treatment, but you can also use silver nitrate washes and benadine in order to prevent some of this. If you are comparing the conjunctivitis that's caused by gonococcal, so gonococcal conjunctivitis is caused by Neisseria gonorrhea. This tends to be early onset, so within days after birth. If you end up having, or a child ends up having excuse me, conjunctivitis is the result of a chlamydial infections, this tends to take a couple weeks to end up treating. So again, you're going to treat with something other than a beta-lactam antibiotic. Something like erythromycin is going to target protein translation. Other diseases, disseminated gonorrheal infections, is DGIs. Basically, this can result in fevers, rashes, these skin lesions. The two things I want you to pay attention to is the superlative arthritis, just like I talked about whenever we talked about chlamydial infections. You can end up getting these septic arthritis. A little bit different here is one, maybe not different. The first thing that's the same, some of this might be the result of cross-reactive antibodies, but this also could be as if you took a sample of the synovial fluid here, you might also see the bacteria actually present within the synovial fluid. So it's speaking from the fact that it's a disseminated infection, it can actually end up in your joints and cause the inflammation as a result of that. It can also be a cause of endocarditis. So you can see how this can go from a localized reproductive tract infection to affecting other places within the body. So this is an example of the erythroid discharge that you would end up seeing from a male patient. The reason why I end up showing this here and differentiate from the next slide is that if you're going to diagnose this in the male, you can basically do a gram stain of this discharge just from this. If you look at it, you're going to see the gram-negative dipococci. You're going to see that within neutrophils. If you end up having a female patient, you're not going to use the discharge like there's not going to necessarily be symptoms. So what you're going to have to do is do some cultures of a cervical swab. And in this context, right, we couldn't do the cervical swab and culture for chlamydia because it was an intracellular pathogen. For this one, you can end up growing it in culture. And what ends up happening is that, gonorrhea tends to, the Neisseria gonorrhea tends to be fastidious bacteria, so it's not easy to grow per se, but you'll use this special agar that's referred to as Thayer-Martin agar. And what it is chocolate agar. So what chocolate agar is that it's red blood cell. It has sheep red blood cells in it, but the sheep red blood cells are lysed so that they oxidize a little bit more. And then you grow the bacteria on that agar that has the lysed sheep red blood cells in a place that has low oxygen. So sometimes, and historically, we use these candle jars, right, to increase your oxygen concentration so that the bacteria would end up growing. And you also have some specific antibiotics on the agar that's going to kill other bacteria might grow as a result of being part of the normal flora. So Thayer-Martin's agar is going to be what you're going to grow it on. Then you could end up doing the PCR analysis. You could end up doing gram staining on this, or you can end up looking for its oxidase positivity or negativity. So Neisseria tends to be oxidase positive, so you can use that as a marker once you have it in pure culture. I already mentioned that antibiotic resistance has become a major issue. So looking back from 2000 to 2018, you can see the steady increase in resistance to Cipro, tetracycline, penicillin. And as a result of that, we obviously don't want you prescribing this to somebody that has a gonorrheal infection. So this is just an update from the CDC since December. And this is now what they are going to end up requiring or suggesting for you for a treatment mechanism. So the ceftriaxone is going to be what you're going to end up giving intramuscularly. They used to say either this or azithromycin, but as you can see, there's starting to be an increase in the resistance to azithromycin, so we don't necessarily want to use it if we don't have to. And then again, you want to treat chlamydia too if it can't be excluded, so you're going to use doxycycline for that. Unless they're pregnant, then you're going to have to use the azithromycin. Again, no vaccine, so you have to limit exposure. Either that, so this is going back to the condom use and other preventative measures so that there's not the spread. So I included the case study on here. I know I'm a little bit limited in time for the amount of microbes that I have to get through in the 50-minute time point, but I want you to go back and look over this. So if you're talking about the case study in short, you have this 23-year-old man that goes to the doctor, is a purulent discharge. He ends up getting given ceftriaxone as the antibiotic of choice. He gets better, but then he notices a milder, more persistent urethral discharge and pain with urination. So we know that he's still having problems. So he goes back to the doctor with his sexual partner. They end up noting that the urethral discharge is kind of watery. They treat both him and his partner, right? After they end up finding that the PCR reaction was negative for gonorrhea. So they switch this over to what antibiotic they're going to use. He ends up, so now they're giving him doxycycline. He doesn't have to come back, but the female ends up coming back as a result of continuous cervical discharge and some problems. And what ended up happening is basically she failed to complete her doxycycline regimen, right? So as a result, she's having problems again, and he'll probably end up being back as a result of her not completing her antibiotics, right? So it's likely that he'll become reinfected. So I know that I didn't ask any questions about this, but you can kind of see how a case might develop whenever it comes to talking about gonorrheal and chlamydial infections. So the last major one that I want to spend time on, and I'm going to have two other ones that I want to mention, is us talking about Treponema pallidum, and this is going to be the causative agent of syphilis. So what you'll end up seeing is that we're going to have a little bit less information about the actual pathogenesis of why the symptoms are going to end up occurring with these. And the reason for that is because really we don't have a lot of information about the pathogenesis because it's really hard and almost impossible to grow Treponema in culture. So we know that it's a gram-negative spirochete. Despite being gram-negative, we know that it lacks some LPS, but much more about the pathogenesis is basically kind of a mystery because of the lack of being able to culture it. If you can't culture it, it makes it really hard to study it, right? So what we do know is that from a microscopic analysis, right, this isn't going to be a bacteria that you're just going to take a sample and do a gram stain on it. And the reason for that is because it's difficult to stain it. You're going to have to use more advanced microscopic techniques. So you might be having to use silver impregnation to see it, or fluorescence. So you see the fluorescence over here, or you might end up using some special lighting microscopy like dark field microscopy in order to visualize it. So the reason I mention that is that as you diagnose, you're probably going to end up using something more like a serological test or a PCR type analysis in order to identify somebody with actually having syphilis, not a microscopic analysis. So the pathology of it is actually really complex. So there are actually 4 different stages that can be identified. Ones that we're going to refer to as acute and subacute. So if you have primary syphilis, so let me go back. So you can have primary syphilis, you can have secondary syphilis, you can have latent syphilis, and then years after being infected, you can end up developing tertiary syphilis. So breaking these down, primary syphilis, so this is going to have an incubation period, between 10 and 90 days, we're going to end up saying. And after this transmission, what you'll end up seeing is that there's going to be this primary or the chancre formation that's going to end up occurring. So you end up seeing over here on the penis, the chancre formation. These tend to be painless lesions. They tend to have a lot of neutrophils in it, and they tend to be well demarcated as characteristics. So you can see them on the genitalia. You might end up seeing them in the oral cavity. For females, they might end up going unnoticed depending upon where they're located at. These are going to end up having bacteria in them. So technically, if you were to do a swab and look for it, you could end up finding them in there. But what ends up happening is that a lot of times people don't go to the doctors for these because they end up healing within a couple weeks. So, excuse me. Sorry, I don't mean to cough in your ear. So here, I don't want you to be confused that I refer to this as a localized lesion. It is localized in the fact that the lesions are found in a location, but realize that the bacteria at this point can't actually spread to the bloodstream, but the symptoms are more localized. You don't end up seeing more spread or more systemic symptoms. The symptoms end up being localized. The people that end up having these or having primary syphilis are going to end up being seropositive. So that's going to be one characteristic that can be ended up being used as a diagnostic mechanism. So why most people that end up developing this primary chancre end up having an immune response that's going to end up being able to take care of that infection. You know, there's a good percentage of these that aren't able to prevent the continuous replication of the bacteria. And of about 50% of those cases that had primary syphilis are going to develop into what is going to be referred to as secondary syphilis, which is a little bit more disseminated in its symptoms when we're talking about it. So from this, you're going to see people might end up having symptoms like sore throat, fever. They might end up starting to lose weight. Oftentimes people refer to this as the great imitator because there's not necessarily strict characteristics that would say, hey, from those symptoms anyways, that this is actually syphilis. These other symptoms that may be present are going to be the ones that are kind of like, oh, that person has this. This is a good idea to think about syphilis in from a diagnostic standpoint. And those are going to include a very distinct rash that they end up developing. And I have some pictures on that on the next slides. Some of these wart-like lesions that end up developing within their mucosa, that these might end up being in their mouth or within their on their genitalia. And a small portion end up developing alopecia, or this moth-eaten hair loss that you end up seeing. So after they have the, let me scooch forward, right? So this is that macropapillary rash that they end up developing that tends to, you end up seeing these spots on the palms of their hands and the soles of their feet. These are teeming with spirochetes. So if you were actually to go and look at this microscopically, you can end up seeing the bacteria actually in those lesions. Excuse me, this is highly contagious at this time as a result of those spirochetes being there. So this condylomata are these wart-like lesions that end up growing. So you see these in the oral cavity, you can see it in the genitalia, and this is an example of that alopecia that results from secondary syphilis. Oops, I'm going the wrong direction, I'm sorry. So a portion of these patients, right, some people will end up being cured at this point or can end up having an immune response that will deal with this. But again, a good portion of them are not able to. Some of these can progress to what's referred to as latent syphilis. The patients are going to remain seropositive, but they don't have symptoms of disease. And then years and years and years later, they can end up developing what's going to be referred to as tertiary syphilis. And that tertiary syphilis is really the very horrific disease that you're going to end up seeing neurologic effects, these cardiovascular effects. You're going to end up seeing bone destruction as a result of inflammation, those type of things. So we're going to move on and talk a little bit about those tertiary symptoms. We're going to jump past those. So again, about 2/3 of the patients, they're going to end up having these those spirochetes persist, and about half of those are going to end up developing tertiary syphilis. So whenever you talk about some of these soft tissue lesions that end up forming that are going to be these dumas, these are going to end up being caused by type 4 hypersensitivity reactions, where you have this really strong inflammatory response that not only causes destruction of the soft tissue in the area, but can go on and actually destroy bone and other connective tissues further in. Excuse me. The other thing that you end up seeing as a result of this chronic inflammation is a lot of vascularitis that ends up causing hardening of the arteries. So you end up seeing from the cardiovascular system standpoint, a lot of these people will develop aortic aneurysms, and this is actually the #1 cause of death in those patients. Or you can end up getting neurosyphilis, which is going to result from the bacteria and the inflammation entering into the brain. So you'll see this general paresis, which is going to cause brain cortex degeneration and cause things like the delusions of grandeur. So you end up seeing, if you go back prior to the development of antibiotics, you'll end up seeing that a very high number of people that were actually in mental hospitals were actually believed to have tertiary syphilis. and it was causing some of those delusions that they were ending up having. Then you can also end up seeing from symptoms of neurosyphilis is going to be this tibialis duralis, which is going to be this damage that's going to happen to the dorsal root ganglia that ends up causing motor problems in individuals, causing ataxia, wide base gaits, and foot slap, those type of things. For congenital syphilis, so this is kind of a little bit different, right? But I want to take a minute to touch about this. Is we've really been seeing an increase in the number of individuals that are born with congenital syphilis in the last 5 to 10 years. Excuse me. So the problem with that, so if we look at the number of individuals that are infected with syphilis, you see more men than women are actually infected or reported. But what we ended up seeing, so a lot of that might be due to the fact that this isn't just a higher increase in men that have sex with women, but because of there being an increase in the number of people infected of men that have sex with other men, that increase is happening in males versus females. But the problem with females being infected is that there's really severe effects on the fetus during developmental effects that end up causing, that can result in congenital syphilis. So what you end up seeing is that if the mother, there's a really high rate of miscarriage, but if it does end up getting to birth, you'll end up seeing stillbirths or neonatal deaths as a result of multi-organ failure. If it's born and it survives, you tend to have really low birth weights and problems with that. Intrauterine growth retardation, you see deafness, arthritis, and these bone and tooth defects, right? So this is another reason why good prenatal care is really important, because you can give an antibiotic to treat this prior to early in development in pregnancy in order to prevent this. And this is some of those examples of some of the bone defects that happens with congenital syphilis. So this is a saber shin, this is a saddle nose. They don't necessarily know why the bone development is kind of messed up in these patients. And this is an example of a mulberry or moon molar that's kind of distinct, and they end up having these Hutchinson's incisors that end up forming. So those are symptoms or indications that somebody might end up having congenital syphilis. So diagnosis, so patient history and the symptoms are going to play a big part of that. Going to be really hard to use some of that microscopic analysis, so it's probably going to be less likely that that's what you're going to end up using. PCR detection tends to be something that's going to be more common, but something that you tend to see are these serological tests. So whenever you see testing for syphilis, you'll end up seeing them talk about non-treponemal tests and treponemal tests. And what this is that for the non-treponemal test, what happens is that there tends to be, the body for some reason makes these antibodies that aren't necessarily specific to syphilis, but they're specific to this protein that's basically found in the mitochondria. I don't know if that's because the cells are lysing and the antibodies are now being able to see something they don't usually see. But this non-specific antibody or antibodies to this non-specific antibodies to this protein can be used as a test for whether or not somebody was exposed to syphilis. So if you see this Venereal Disease Research Labs or the RPR, the Rapid Plasma Region tests, what these are non-treponemal, so that's meaning that it's not specific to treponemal antigens. But what you can do is you can take that protein, put it in attach it to an agarose gel type thing, put the patient's serum in, incubate them together, and if you get agglutination or clumping, then you know that person has antibodies that would be specific to them. So you can see that down here. A non-reactive test not showing that clumping, a reactive test showing that there is clumping occurring, and that's an indication that somebody might have might have syphilis. This can also, so previously this is what youth blood banks used to identify. Back when most states ended up requiring syphilis tests before marriage to get your marriage certificate, that's what they ended up using to test. One thing that this is still useful for is that you can end up seeing how effective treatment is. If you look at these titers over time, right, you will see a decrease in the antibody titers against these particular proteins. But if you started giving antibiotic treatment and it's responding, the bacteria is responding, you should see a real sharp decrease in those antibody titers real early after the administration. So while either of these can be used for primary, secondary syphilis, the VDRL tends to be used for the neurologic syphilis diagnosis. For the treponemal tests, what you'll end up seeing is that they'll use a fluorescence test where they'll take bacteria, they'll put a patient's serum on it. If there's antibodies in the serum, it'll bind to that particular the bacteria. And then they can use a secondly fluorescently labeled antibody to see whether or not that your serum had antibodies that actually bound. It's kind of like an ELISA. There's also ELISA tests that are rapid tests that can be used. And there's an agglutination test that can be specific to the treponemal antigens also. So they tend to end up using those. Realize that if you historically were exposed to treponema, you're going to end up being seropositive, end up having positives against this. Whenever you're talking about these non-treponemal ones, these tend to be more with active infections to be able to show that they have active infections. Treatment, penicillin intramuscularly. If you're talking about neurosyphilis, you're going to use intravenous. Again, no vaccine, limit exposure is going to be really important. And I already mentioned this, is that idea that males tend to end up being undiagnosed more often than females. I'll let you guys look at the case studies on your own since I'm running short on time here. I put the answer down here at the bottom, so that should just be a helpful hint for you. I did want to make one mention. I'm not going to test you on this, but you know, thinking about some of the health disparities between Blacks and whites in society today, especially when it comes to COVID. There was a recent article that was published a couple of years ago that was kind of looking at the correlation between the Tuskegee syphilis trials. So if you don't know what the Tuskegee syphilis trials were, basically in Alabama, they recruited Black men that were infected with syphilis. And they were basically evaluating how the progression of syphilis over the years was. Even after they had the ability to treat them with penicillin, they didn't provide that treatment, and they continued those studies on into the 1970s, right? So this has been a big concern of trust in those communities for the health community. And they basically went through and discussed those correlations on how this impacts, you know, so we're talking about, you know, 40, 50 years ago, what happened in those communities and how that's impacting healthcare disparities in the United States today. So it's kind of interesting. Last two I want to mention, I said these are going to be fast one slides, are two other bacterial, they're both bacterial diseases that are transmitted via sexual interaction. Both are going to be gram-negative. This Haemophilus ducreyi is going to cause the disease that's referred to as chancroid. Here you end up seeing these chancres form. They tend to be very painful and ulcerative. The big point of this is to look at the fact is they're not necessarily very common in the United States, but whenever you look worldwide, 6 million cases of them exist worldwide. And they actually are a big reason that they predispose people to HIV infections. So obviously worldwide, you're talking about increasing the rate of HIV as well as having the sexual transmission of this is a problem. So I want to make sure that you're aware of this one. At least you have a little bit of knowledge of it. This can be treated. So it's diagnosed via culture. So you can culture it and do gram stains on it. You can do PCR on it, and you can treat it with the azithromycin. Another one that is not common in the United States, but occurs in other tropical and developing areas is this granuloma inguinale. It's called spike Klebsiella granulomatous. It's another gram-negative. And in this one, you'll end up seeing that it causes these lesions that are these ulcerative lesions. They tend to be very deep tissue. And actually, you can end up requiring amputation in these patients. What ends up happening is these bacteria end up infecting macrophages, and you end up having these subcutaneous granulomas form. These lesions tend to bleed a lot, and they can end up disseminating into other organs, bones in the mouth, right? So obviously, that is unpleasant. but not necessarily very common in the United States. But if you're thinking about other places around the world, they do have a significant impact. Treatment for these guys are tetracycline. And the last thing I'm ending on is going through, I said prevention, prevention, prevention in all of these because there aren't necessarily vaccines available. So I provided some documents from the CDC about effective condom use and ideas of what you might want to suggest to your patients if you're going into infectious disease. Does anybody have a questions? I'm sorry, I'm a couple minutes over. All right, well, you have my email at the beginning of the PowerPoint. If you guys have questions, feel free to shoot me an email and we can chat. Oh, wait, hold on, I see one in my chats. Oh, just thank yous. Thank you. Have a great weekend.
Thank you.